Hello and welcome to the next episode of the Complete Physio podcast. Today we're joined by Stuart Wishart, who is a very, very experienced physiotherapist in ACL rehabilitation. So we're going to be talking about everything about ACLs, and we're particularly going to be focusing on the ACL reconstruction, which is a very, very common operation that's been carried out for many, many years with a lot of success. So if you're somebody that's about to go in for an ACL operation, then hopefully there's lots of information in here that you'll find useful. So, Stuart, thanks very much for joining us. First question is, if somebody is sitting at home and they're, say they're going to do have an ACL reconstruction in a couple of weeks, what sort of advice would you give them to try and prepare for that operation?
I think the main goals before your surgery are, ideally you want your knee as quiet as possible. So ideally no swelling or only very little swelling at that point. Ideally you have a fully straight knee already and as much bend as possible. But I guess I've seen people go in without full flexion and that's still been okay. But the surgeon's going to want a knee that moves well and that it isn't swollen and that still doesn't look too unhappy. And then I guess we tend to see the stronger you are before your surgery, the better you're probably going to come out the other side. So if you've got good quads activation back, if you've minimized how much quads you've lost, if you've been able to do some exercise to build some strength back up there, and you're able to keep your hamstring and your calf and your glute working a little bit, then you're going to set yourself up much better for the surgery that's coming up.
Perfect. So people use this term prehab, don't they? So doing exercise before your operation to get ready for it. So you want a knee that isn't swollen, so people can put ice on it. They could put a compression bandage on it, and obviously not overdo it. If they know that playing football is going to, well, they're probably not playing football, but going for a long walk swells up their knee, then it's probably best not to do that for a couple of weeks before the operation. Yeah, definitely. As you say, a quiet knee.
Yeah. You've got to moderate your activity based on what it's tolerating, and then beyond that, elevating it, icing it, you might need some compression. If you're about to have the operation, then there may be some value in renting a game ready or something like that a little bit earlier if you're still struggling with the swelling, because that's going to be quite a lot of value after the operation as well.
Yeah, so that's good advice, isn't it? So what we're talking about there is, obviously physios always saying put ice on it, but now we've got these machines, game ready, Physio Lab. So these are ice machines that compress at the same time. They use them in elite sport, and as you say, they cost a couple of grand, I think, to buy, don't they? But you can rent them.
Yeah, you can rent
online.
I've had a couple of patients buy secondhand versions of as well, if they've been using them for prolonged periods. But most commonly, the surgeons these days will want you to maybe rent it for 4 to 6 weeks post-op, and it's much cheaper than buying it normally.
And we certainly recommend it. And it could be a way of getting that swelling down before the operation,
if needed.
And then using
I think it makes a big difference.
I totally agree. Because as we're going to go on to, is you want that. Obviously, after the operation, you're going to have a lot of swelling. And getting rid of that swelling as quickly as possible is actually going to be one of the key things. I think the other thing that I try and get people to understand and get themselves psychologically ready for what is a long, painful at the beginning sometimes, and a long rehab process. So I think hopefully watching things like this, we'll be talking about something called the Melbourne protocol, which is something that can guide physios, or we use a little bit to guide, loosely I suppose, but we use it to guide our rehab. And actually the patient looking at what is involved in the rehab process after the operation, I think can really help them get ready for.
I think it's really important. I think surgeons these days are quite good at setting quite realistic expectations and time frames for patients as well, which I think is really important, because we need patients to know exactly how long it's going to take to recover.
It takes a long time.
It takes a long time. We need them to know in advance how much work they're going to need to do, because it takes a lot of work from them outside of the clinic as well. And I think that education before the operation is really important, because they need to make sure they can fit the rehab into their schedule. They need to adjust their work. They need to make sure they have enough support at home.
That's really important.
I think everyone knows for the first few weeks that they're going to be a bit sore and they might be on crutches, but we tend to find if those first few weeks pass and people expect they're straight back to work and they're full-time looking after the kids and not got any extra support, they very quickly fall behind schedule because it really does take quite a bit of time and effort initially. And
it's also logistics, isn't it? If you've got kids that you've got to take to school or nursery,
exactly.
You know, and you've got a big swollen knee, it's going to either take you a lot longer or somebody else needs to do it. So they need to plan probably the first couple of weeks. They're definitely going to be limited, aren't they? So they need to plan that.
And I have more and more patients that are very aware of that in advance now. I think surgeons have those conversations quite nicely these days. And some patients will opt to delay the surgery slightly because right now is not a good time with work, or
going on holiday.
Exactly. Holidays coming up, or there's a wedding coming up, or they know that they're going to need to be pretty full on with the kids. And as long as they know what to do in the meantime, they don't have much to lose for delaying that surgery, provided they meet certain criteria.
I think you're right. That's the question, isn't it? Are you going to have a worse outcome if you say, actually, I want to go on holiday for a month. I can't play football, but actually I can still get around. I want to do it, you know, when the weather gets worse. And the evidence, and depending on whether they have other associated injuries, I think with the cartilage, most of the time delaying it isn't going to affect their outcome.
Yeah, definitely. I've seen in recent years some surgeons choose to delay it a couple of months to allow the patient to engage with physio for a couple of months, get that strength, get that movement, knowing that they'll probably get a better outcome and it'll be a better operation for delaying it slightly. I think the research backs that. I think unless there's a secondary injury,
like a meniscal tear,
there doesn't necessarily need to be a rush straight into surgery, even if you know you're going to have it. Some people are ready immediately. But I think all those other decisions will dictate for people whether it's something they go straight in for, or whether they actually give it just a little bit of time.
I saw a lady actually around February, she's been skiing, tore ACL, and she was absolutely desperate just to get the operation. You know, a lot of people just want to get on with it and get the operation done. Her knee was massive. And the surgeon said, look, I don't want to do anything on this for about a month because this needs to reduce. She also had 2 young kids, and although she was like, I want to get going, and she was a single mum. And so he was like, look, you've got to commit to this. Because the problem is if in that first 2 weeks, you can't commit to your rehab, you can't put your ice on, you haven't got time because you're running around, literally running around, your knee swells up, and before you know it, you can't get your knee fully straight. And your outcome's going to be worse.
And your recovery will take much longer at that point. So whilst you've saved a month for getting the surgery done immediately, you probably add a few months to your recovery. So you really don't save any time at all. You probably cost yourself time.
That's a good point. And a good outcome. Which is the main reason for doing it.
Because I get it. I can see why patients want to get it done straight away, because if they've just been told it's a 9 to 12 month recovery, if I add a month or 2 onto that by delaying the surgery, it turns 9 to 12 into 11 to 14. It's a lot to get over mentally, but you kind of almost sometimes do save some time for delaying it, because you can then just crack on with your rehab straight away afterwards. But
and the reason this lady wanted to get on with it is because she wanted to do the ski season the year after. But again, you know, it's by delaying it, which is what we did, and she's done absolutely fine. Like she's doing very well. It's probably not, maybe toward the end of next season, she will be able to do, you know, come March, April, she might be able to do it. But the worst thing you can do with rush it, because if you're not ready, you re-rupture, you're just back to square one and probably slightly worse.
Well, that's it. I mean, it's a long process anyway. There's nothing worse than having put all that time and energy into it and then having to go back to square one. It's very mentally tough to overcome that, I think.
Okay, so hopefully somebody's going into the operation with information about what's expected after. They've looked at logistics, they've got some extra support, they know roughly how it looks. Hopefully they've got good muscle activation, their knee fully straightens and bends pretty well. Obviously that will depend on whether you've got a meniscal tear as well. Hopefully the swelling is down, so they don't have a puffy knee and they're good to go. So they have the operation. Now, we've got other podcast episodes about what grafts to use and the pros and cons of that, and actually a little bit around what is involved in the operation. So let's skip that and let's go on to the sort of general principles. So do you want to just talk us through those first few days? Most people, they may stay in for one night, but they're not in hospital long at all. talk us through those first few days when you get home, what the priorities are in that first few days towards a week. So that early phase of rehab.
Yeah. I mean, there'll be swelling, there'll be pain, your knee will feel stiff, you'll still be on crutches. I think people are often surprised. Routinely, they probably won't put a brace on people unless there's a secondary injury. That surprises patients sometimes. It surprises them that they can be walking pretty immediately with
full weight bearing.
Yeah, with full weight bearing. And although crutches will be there initially, we're ideally getting people off crutches as soon as they feel comfortable to. Which doesn't always take that long. I think the initial keys are, we want to get the knee as straight as possible as soon as possible. So you'll often be given exercises in the hospital to bend and straighten the knee, to tense the quads, to tense the glutes. As you're a bit less mobile than normal, they'll get you pumping your feet and your ankles to get the blood flowing to minimize clot risk and things like that. But I find that the two biggest things we want to focus on immediately are straight knee and quad activation.
And swelling.
And swelling.
Those three.
And patients will always be told this in hospital, but by the time we see them a week or two later, they've often been pretty good with the elevating and compressing and icing, and they're often working on their knee straightening, but they've been told to tense their quad. But it's very hard when you have a knee that doesn't fully straighten initially, and when you're quite swollen, there is inhibition of that muscle. So the swelling is kind of fighting the muscle activation in a way. So I think the biggest thing I tend to find early is that although people are trying, they're perhaps not getting a very full quads activation. And it always...
Because after the op, your knee doesn't feel quite like your knee, does it?
No.
You feel disconnected.
You're right. It takes a while for it to start to feel a bit more normal again. And it always shocks patients how quickly their quad muscle will start to vanish.
24 hours.
We
know that it starts to waste in 24 hours.
And we see them a week or two later perhaps, and they're doing as much as they can, but often they don't realize exactly how important it is to get that quad working immediately, because by 2 weeks, if you've not had a very full quads contraction, we're already seeing quite obvious signs of muscle wastage. And it just puts people behind the eight ball immediately. So that's nearly always the thing that I focus on the most in that first session, is to make certain that they're getting as much of that as possible. Because I think that's the thing I tend to see deteriorates the quickest.
I agree. So, and I was thinking, between us, we've got about 40 years of experience of seeing these ACLs. And I think a good physio simplifies things and gets you to focus on they don't say you need your knee straight, your knee bent, you need good, they're going to focus you at certain weeks on certain things. And those first 2 weeks, I totally agree. Swelling down, and we would advocate using one of these compression things such as a Game Ready.
Definitely.
Getting the knee straight quickly, because the longer you leave it, and obviously sometimes, I'm sure you've experienced, and it does vary according to the patient. It does vary sometimes according to the graft and exactly what they've done in the operation. But it can be sore getting the knee straight initially, can't it?
Yeah, definitely. And I think when it's sore to straighten your knee, it's inevitably sore to tense your quads as well. They go together. So you kind of ruins two things at once. And so even simple things like, if you roll up a towel and put it under your knee when you're trying to do your quad tensing, it reduces that pain. It actually allows you to tense the quad. And then we tend to see, when we take the towel away again, the knee's a little bit straighter because you've just put people in a more comfortable position. And that's a very simple adjustment to what they're already trying to do. But little things like that can sometimes make quite a big difference.
And also from a physio point of view, we do use hands-on techniques to help reduce the swelling. We also do some mobilizations of the knee joint, because normally we can push that knee a little bit more than the patient. So that can be useful. And the other thing that we use in clinic is Compex, so muscle stim. So do you want to give us an idea about how that works? Yeah,
definitely. So it's there's pads, you put them on certain points of the muscle. I use a brand called Power Dot, which just connects to my phone. That's probably the cheapest available good one that we use, and you tend to get a fair bit of life out of those pads as well. And it all connects through Bluetooth, and you can simply just set programs to electronically stimulate the muscle.
Yeah. So most people think about the ab trainers, don't they?
Yeah.
And it is similar.
Or they think about TENS machines in pregnancy and things like that. And it's the same thing.
Yeah.
We just use it in certain areas with certain functions, and it's predominantly the quad that I'll end up putting it on because people don't lose hamstring as quickly.
Yeah.
Most people don't lose too much calf if they're walking regularly fairly soon. So it tends to be the quad we focus it on, and we can turn it up as high as we need to actually get the muscle contracting involuntarily. Yeah. And we see massive changes within session in someone's ability to then tense the muscle and straighten. And
because the main thing that stim's doing is getting all those motor units to recruit, isn't it?
Exactly.
It's a recruitment. Initially, it's about recruitment, switching it back on.
That's the biggest issue. That's what the swelling inhibits the most. And
the pain.
Is that you don't get the same neural recruitment to the muscle, therefore the muscle can't turn on as well, and therefore you start to lose the strength. So you're not going to use that machine to build a big muscle, but you'll simply turn all the nerve endings back on, improve that pathway, and then it's up to us to find exercises to actually work the muscle in a way that will kind of build it from there.
So swelling down, quad activation, knee straight are the sort of main things, aren't they, that in those first 2 weeks.
Yeah.
And although we do give out exercises to start improving bending, because you do need to be doing that as well, we're certainly not expecting people to have full bending at the end of 2 weeks. But I don't know about you, but for me, I definitely want a knee fully straight at 2 weeks, if not before.
Yeah, I think the old criteria was 4 weeks, but I think we find if for most people, if we do the right things, I think it comes earlier than that. The sooner we can get it, the better.
Yeah. And you mentioned, so people are going to come out of, they're going to have crutches. Everybody will have crutches generally.
Yeah.
It's just there to basically help you get around. It's not that you need to put less weight through the foot to help healing. It's not like a bone, for example, or with Achilles ruptures. But the other thing that some people may also have, and you mentioned a lot of people don't do it, but there does seem to be a slight trend coming back to bracing a little bit. Mm-hmm. And I've got one surgeon I know has gone back to bracing. Yeah. Is that something that you find helps? Well, I'm sure you've seen people with braces after. Yeah. Do you find that helps, or do you find it hinders?
I don't think it hinders if people have had good education and they still know what they can do within it. If it's there for a very short period.
Yeah.
If the brace is only restricted to certain angles or relatively unlocked, then we can still use our muscles somewhat normally when we're walking, and that's definitely preferable. Yeah. With more aggressive surgeries and the need for stricter bracing protocols, it becomes a bit of a necessary evil at that point.
Yeah. They may have a brace, though, if they've had a meniscal repair or something else as well.
I typically see it more with the meniscal repairs. They'll need to brace. And again, depends on the surgeon's protocol and how significant they've needed to be within the operation. But the challenge is always when the brace is a bit more restrictive, because they're trying to protect the repair a bit more, which in some cases is definitely warranted, but that will definitely delay our initial recovery. Yeah. We'll have much more wasting of the quads in particular, probably the calf as well. Yeah. We're definitely slower to achieve movement benchmarks.
Normal walking as well might take a bit.
Slower. I tend to find the knee remains swollen for longer because people just aren't getting movement. So it's definitely a challenge, and it definitely delays that initial recovery, but if it's what is needed to protect that particular repair, then so be it. But
I had a patient a few years ago. He was a young kid, 18, having his ACL done, and he was a bit of a wild child. Yeah. And he turned up to clinic and he had quite a big brace on. Yeah. And I texted the surgeon and said, well, you don't normally put a brace on. He said, I don't trust this one. I need to slow him down. Yeah. And so sometimes it's for those reasons as well. But if you put a brace on somebody that's also already quite anxious, quite pain sensitive for a better term, that can slow them down.
That makes it tough.
Yeah, that can make it tough.
That makes it tough. But if the surgeons very clearly outline why it's on and what they can do outside of it, it should hopefully minimize that. But otherwise it's difficult. Yeah. I saw a patient yesterday who had the meniscal repair at the same time. But the bracing protocol's not been too strict.
Right,
the brace is still on, and
so they did the ACL recon and the meniscal repair.
Brace will be on up to 10 weeks, but it was only locked for the first 2.
Yeah.
And then he's had it 0 to 90 up to 6 weeks, and then from 6 to 10, they've had it completely unlocked.
So you could get fully straight, because obviously
It probably has increased his loss of the quad slightly, but otherwise he's progressing virtually to the same benchmark. So I think it will only delay our ability to get into the bigger strengthening things by a couple of weeks, and he's not really any worse off for it. But he's quite relaxed, and the surgeons already educated him on why it's there, and it's just given him a bit more support and security at a time where we want that meniscal repair to kind of really be protected. So in those cases, I don't think it is that detrimental at all.
Sure.
But like you said, it's different in different patients with different levels of anxiety and with different protocols based on exactly how protected.
And it might vary a bit surgeon to surgeon.
Yeah, it definitely does, I think. Yeah.
So a couple of questions in that first phase. When would you expect a patient to go off their elbow crutches and be walking unaided? Like, when would you suggest that's a good sort of timeline for that?
If they're not braced, and there's no need for extra protection, if it's just an ACL reconstruction and the surgeon's quite happy with the quality of that repair, we'll often see patients walk into their first session even with the crutches kind of there.
That could be like day 3, day 4, which is normally when we see them, isn't it?
They're still using the crutches for a bit of support and stability, and they're still not comfortable, but they have the ability to do some walking without them. I often find within a week or 2, patients just often don't feel they need them. Yeah. And I'm happy.
I'd say by week 2, you don't really want them, although lots of people keep hold of them to make sure they get a seat on the tube and that sort of thing.
Exactly. But
which is probably quite sensible, actually.
Yeah, and that's probably why they brought the crutches in, because they've come to see us in clinic, they've travelled to get to us. But often they'll have them both in one hand to the side. They'll look at you thinking that you want them on the crutches to walk in, and I'll normally grab them off them and say, if you can walk, then we can walk into the room. So, I think most of the time, if someone still needs crutches beyond 2 weeks, then there's something that's slowing them down.
Something slow. Yeah, and it doesn't mean anything's going to go wrong, but it might just be a little bit slower, which again is not the end of the world.
It could be a pain thing. They could be experiencing more swelling. They might just be a bit anxious, and they might just need a chat with you about what's normal and what's not. But I find most patients within that first week or 2 find that they're a bit more of an accessory than they are.
So a lot of questions that, patients will always say, well, you've given me these exercises. How often should I do them? Should I do them all together once a day? Should I do 3? What do you generally, and I'm sure it varies, but what's your general advice around the frequency of exercise?
Early days, it's little and often. I think frequency is key. And that's why it comes back to fitting the operation in at a time that suits you, because if you can't be regularly elevating and icing multiple times per day, if you can't be doing these exercises 3-4 times a day at least, I think you're probably going to slide behind schedule a little bit. They're all very basic and easy and quick to do, or easy. I mean, they're in pain and there's a bit of swelling, so there'll be some work there, but they're not advanced exercises. They don't really need extra equipment. They can be done anywhere, but I tend to find that if people can do a short burst of exercise 3 or 4 times a day, they probably get more out of it. Because especially when there's swelling, if you've gone and stretched and bent and straightened that knee, and then you haven't really moved it for 24 hours, by the time you come back to it, the swelling's still there and everything just stiffens up again. So I'll normally tell people, if you can even do 5 or 10 minutes 3-4 times a day, that you probably get the best result early until we start to move to more advanced things.
And it's not a prescription, is it? Like once somebody's got their knee straight, probably do the exercise less, can't they? And we're on to the next bit.
And that's the key. I think you need to pick people's strengths and weaknesses. They don't need to do the same list of stuff all the time if certain criteria have already been met. They can just focus on the things they're struggling with. And I think that's the key with physio in the initial stage. It's not necessarily rocket science, but it's nice for people to be told, you've already ticked those boxes. You can really reduce the time you're spending there. You've got to put that time into these couple of things, because you may be a bit behind schedule there.
But it is so important that you're seeing a physio that sees a lot of these. Because then you've got that comparison, and people will always say to you, am I doing all right? They want that. And if you've seen a lot, you know what roughly good looks like.
There's lots of research, there's lots of protocols, there's it's a bit less time-based these days, apart from a few factors. It's a lot more criteria-driven. And someone who sees a lot of these knows that criteria, like the back of their hand. And it's easy to know if someone's ahead of schedule, behind schedule. Because that's the other thing. I've got a guy at the moment who has been very comfortably ahead of schedule at every bit of the criteria. But I guess you also need to know what you can't push him into quicker so that he doesn't expose himself to unnecessary risk.
Where he may re-rupture.
Yeah, because if he was going by feel, he would have been in the gym doing proper stuff within a few weeks. He looked good enough to. But I just needed to slow him down a little bit because we didn't want him in positions that were going to be of risk that early, even though I felt like he probably could, because he had very little swelling.
And I think that's what people have to fundamentally remember, is that from a physio point of view, we're strengthening around it, we're getting the full range of movement back, but fundamentally it's the surgeon that's done the graft, and the graft is often a tendon that has to basically, for want of a better term, ligamenticize. So that tendon has to turn into a ligament. There's nothing you can do to speed that up. And we know that's going to take 9 months to do that. And even if you're meeting all your criteria, we're not going to turn around to you and say, great, go back to football at 6 months. I mean, they don't do that in elite sport. Sometimes they will, because they're getting paid a lot of money every week. But the risk is then there, and that's a managed risk. But, even if somebody's got all their criteria hit at 6 months, we're not going to let them go back probably for 9 months at least.
Yeah, definitely.
What's your thoughts around that?
Yeah, I mean, spot on. I think you've just hit the nail on the head that there is absolutely risk involved in that, even in the professional setting, but there's money and time and careers on the line, and sometimes they justify the risk that's there. But for someone who's not a professional athlete, who's put all this time and energy and sometimes money into these things as well.
Well, time off work, physio sessions,
a lot of coming into physio, missed holidays, altered family schedule. What you said is true. When people often feel at their best through those like 3 to 6 month periods where they're really pushing the gym and they start to feel very normal day to day. And they're looking at you and wondering why they can't go back to more because they feel great. That often correlates with the exact period of time where they're probably at the most risk graft-wise. The graft gets weaker before it gets stronger, as you said, that ligamentization process. And if we're not aware of that, then we can absolutely send someone into a re-injury almost immediately, because they won't feel that weakness.
No, not at all.
They
can't feel their graft.
No, not at all. They will feel physically very good. And so I think it's really important to have that conversation, because they will always turn to you and ask, why can't I do this? Why can't I do that?
Because naturally you think that as time went on, that graft will get stronger. But what we're saying, and as we know, is actually there's periods through that rehab where it could be month 3, 4, that graft's actually weaker.
Definitely.
Before it then gets stronger.
And like you say, you can't fight biology. No. And it's our job to not stuff up all the good work the surgeon has done. Because their job is largely done by that point. But we can definitely do someone a disservice if we don't respect the natural timeframes there. So I guess in elite sport, they're pushing the absolute limit of that process. But I'll routinely say it doesn't matter how well our recreational athletes are going. The research is quite clear that anyone going back pre-9 months is dramatically increasing the risk.
And that 9 months is a bit of a magic number in the research, isn't it?
Look, I would say most recreational athletes are not ready at 9 months based on the protocol and the criteria anyway. Most of the time, just because of the time.
And that's back to full sport, though, isn't it?
Exactly.
So they might be running.
They'll definitely be running by that point.
They're not doing competitive contact.
No. And the vast majority of people, based on the amount of time they have to put in, will probably take 12 months plus in the recreational world, I would say.
And don't rush it. So last thing, in that early phase, patients will often say, well, I'm doing my knee exercises. What else can I do? So can people go on a bike? Can people swim? Just throwing things out there. And what can they do upper body wise? What's your general advice around that?
Most of the time, surgeons are pretty happy for people to be on the bike pretty early. And we often
it's a great way of getting the bend going, isn't it?
We use it as a range exercise more than anything initially. As we're thinking about what we can start to do in a gym environment, maybe weeks 4 to 6, most of the time people are able to get the legs moving on a bike and start to get a little bit of cardio out of it. Swimming, not breaststroke, but often we can be in the pool moving. We can be doing some light, maybe crawl or backstroke or something like that, or even just being in the pool doing exercise-based things that aren't always swimming can work really well. But you often need the wounds to be, you need a few weeks for the wounds to be
you can't go in with
we don't want any infection risk. So the wounds need to be closed, no signs of infection, clearance from the surgeon to get in the water. So normally that's 3 or 4 weeks in, and we're pretty happy with that. In the gym, we can adjust all sorts of things. You're not going to get on a rowing machine because you're probably not going to feel like you've got enough movement in your knee straight away, but we might be able to do some modified stuff on a ski erg. If people have assault bikes,
cross trainer,
they can do intervals even just using the upper body with the feet on the pegs.
So there's a lot that people can still do, isn't there? They can obviously train their upper body, they can train their core.
It depends how much time they've got. Like if they're keen to get straight back into things and they've got the time to do it, then the gym machines are great because you can do upper body work in really simple movements without any real risk to the knee because you're sat on a supportive bench the whole time, and you're not necessarily having to pick up heavy weights and put them on racks. You can just pin load it and off you go. So
that's good.
Core work can often start early, upper body work can often start early. It's simply a matter of how much time someone has to fit it in.
People are always amazed with how much you can do. Even in those early days. So that sort of got us up to week 2. So hopefully our knee's nice and quiet. Our knee goes fully straight. We're starting to get probably 90 degrees, maybe a little bit more bend. And we've got some good muscle activation. Maybe we're using our Compex and obviously we're using our ice machine. Do you want to just talk us, we talked about the Melbourne protocol, and do you want to just roughly talk us through the next few phases, how they look, and then we'll go back and talk about each phase a bit more individually.
So the phase next is trying to build more strength. So we're assuming swelling it won't be gone, but it'll be settling. We're assuming a fully straight knee, decent quad activation, and a knee that's beyond 90 degrees, definitely. Maybe coming up to 100, 110. Then we can start to do most exercises. So then we can start to think about some bodyweight exercises. We can start to think about a gradual return to gym, using some gym equipment. Leg extension is something that has come into play more, not just in recent years, but in recent times, because the research around that has changed. And from week 4, we can potentially start to use that in a modified way in certain ranges to start to get some isolated quad strength built back up.
So it's probably worth mentioning at this point that you can do an open. So there was controversy. It is quite a long time ago now, but there are a few people that will have opinions differently to this, but I think the general consensus from the research is that you can do what's called open chain and closed chain exercises. Do you want to just talk through what we mean by that? And certainly from our point of view, when the time is right, we will certainly use both, won't we?
So closed chain is foot on something remaining still. So a leg press is closed chain, a lunge, a squat. They're closed chain. Open chain is the foot is moving. So a leg extension, a hamstring curl, things like that are open chain.
Where it's not in contact with anything.
The original concern was that those open chain exercises, particularly the leg extension, there's not been so much concern around the hamstring curl, but the concern was that the movement under load would place an increased strain on the healing ACL graft. And that would
potentially stretch it.
And that would lead to laxity or increased movement or instability longer term. And they've researched it a lot more in probably the last 10 or 15 years and found that concern is perhaps valid at certain ranges, so that the peak strain through the ACL occurs at about 10 or 15 degrees. So
open chain.
As the knee is nearly straight, essentially. But once you drop past 45 degrees, the strain on the ACL graft in that range goes to 0. And they've done studies to compare the strain throughout that movement versus step-ups and squats and things like that. And they've found...
Because real strain on the ACL has to have a rotational element as well, doesn't it? And obviously these are sagittal plane exercises.
And there's strain on your ACL getting out of a chair. There's strain on your ACL when you walk. But it's an acceptable level. And so the research has kind of matched that level to what we can achieve on a knee extension. And the protocol that's come out of that and since been researched is we can get people working within a range of 90 to 45 degrees under load from 4 weeks.
Yeah.
And there is no extra strain on the ACL that's healing at that point for doing that. And I think they studied that and found that when they retested laxity after a 3-month period, that people were no different to those that had done it. So we're relatively comfortable with that from 4 weeks to 12 weeks. Yeah. And then at 12 weeks, we then allow people to go through full range and expose themselves to the positions where the strain is a little bit higher. We're more comfortable that the ACL can tolerate it at that point.
But that strain is still not going to be enough to actually stretch it anyway.
It's very comparable to squatting, step-ups, things like that. And those closed chain exercises are also good. The research has shown, and we clinically see this as well, is that there's just a lot more capacity for people to cheat and find their way around their problem when they're in those positions. So commonly people will shift off their injured side when they're squatting. Commonly they'll let their knees stay a bit stiffer and they'll use their hip to kind of get a little bit deeper. So there's a lot of ways to, even without thinking about it, avoid loading your knee and your quads with those closed chain exercises. So they're definitely still good.
Whereas open chain is very specific, isn't it? Maybe less functional.
Definitely less functional, but
if you want to build strength.
This is it. And in the early stages, we're not too worried. We've got other ways. We get people doing a little bit of balance and things. We've got functional things in there, but we just need the quad to fire up. And we just need to stop that atrophy that's occurring and start to build the quad back up. And there's no better way to do that than an isolated leg extension within safe ranges. So we find that the exercises complement each other well. You get different things from different exercises.
And this is where, you do need to have a physio to guide you through it and somebody knows what they're doing, because if you do put, let's say, for example, without getting too technical, somebody still week 2, week 3 has a quads lag. So a quads lag is where you can't fully straighten your knee. We can get it there passively, but actively they can't straighten it. And then you put them on a leg extension, it's clearly going to load up that graft or potentially load that graft up more. So, and that's where you were talking about more about milestones and criteria based, that if you can do X, you can go on to Y, and that's really important. And also people that are maybe just trying to do it on their own, which I appreciate some people aren't, particularly with, say, waiting lists on the NHS now and that sort of thing. You just got to be careful. It is not one size fits all, is it? We're always doing, I don't think there's one ACL we would have rehabbed exactly the same way on exactly the same week that we've progressed this way or that way.
Yeah, exactly. We definitely have moved away from, there are still some time elements to it, as we've discussed, but we've tried to move a long way from it being a time-based rehab. It has to be criteria
Week 4,
based.
Everybody does this. Week 8,
you tick one box, you move to the next thing. You tick that box, you move to the next thing. And something like the Melbourne guide is a very handy guide to see that laid out in front of you. I appreciate it's still maybe difficult to follow start to finish without guidance and without some alteration and some tips and tricks, but it's a very clear pathway as to what you need to achieve before you can do the next thing, and then what you need to achieve. So we use that as a framework, definitely, and then we kind of adjust it to each person and add and subtract little things depending on what people are trying to get.
We'll put a link in the notes about the Melbourne protocol, but it basically, if you Google Melbourne protocol, it will come up with lots of good information.
Definitely.
Now, the other thing that we sometimes use, because what this phase is all about trying to build that muscle strength, isn't it? Sometimes we will use something as an adjunct called blood flow restriction training, and people have probably heard about it, or if they're looking into the rehab process, it might come up. Do you want to just give us an idea of what that is and whether, not everybody should be doing it, but what people might benefit from it? Certainly in elite sport, it's used a lot.
Yeah. I mean, we've been rehabbing people for years without it, so it's definitely not a necessity. I would say it probably is for those that are really trying to accelerate their recovery.
Although we've also explained you almost can't.
Sensible timeframes. But if someone really wants to crack on with the strength work, and we see that it's safe for them to do that, it'll probably accelerate the rate at which they can get those muscles working in a safer environment early.
Yeah.
But it probably is also there for people at the other end of the spectrum who have really dropped behind.
Yeah. Who need to get that quads. And also people that don't have access to a gym. Let's say they go traveling for 2 or 3 weeks, which we wouldn't advise week 3, 4 or anything like that. Yeah. But that's also a way of maybe getting some muscle strength.
The research shows is that you can stimulate the muscle without much load and without equipment, and therefore it puts very little pressure on the knee itself.
Yeah.
In a way that's quite comparable to actually having access to like gym equipment.
Yeah.
And so it's a useful tool in those scenarios. The cuff goes right at the top of the thigh.
So it's basically like a tourniquet, isn't it? Like a blood pressure cuff that goes around the top of the leg. It reduces that venous return. You get a buildup of blood and essentially growth factors in that area, and then you can build muscle quicker but at a lower intensity.
Yeah, and we've got to measure it to make sure we know what levels are safe to use it on, and patients need to be aware of those levels.
And these are specific devices. We don't want people going out and just buying a blood pressure cuff and I don't know, an elephant's blood pressure cuff and putting it around their leg. But so these are specific blood flow restriction training devices.
And it takes some getting used to. Yeah. It's not particularly comfortable initially. People that are quite used to heavy workouts in the gym prior to tend to get on with it fairly well, but it's a very odd feeling the first time you use it to feel that much fatigue kind of sitting in your leg. But it's like you say, it can stimulate the muscle really, really heavily and induce a lot of fatigue and growth factors. And the research is clear; it can allow return to strength quite quickly in environments where we don't want to put much pressure on the joint or environments where people don't have access to that external load. So
an example might be that somebody, for whatever reason, and some people are getting a little bit more pain, you put them on the leg press machine and they're like, every time I do that, it hurts. Yeah. It might be that you can then use blood flow restriction because then you're still getting the muscle gains but at a lower intensity. That's probably one example, isn't it?
Yeah, definitely.
Where you can use it.
We can use it to lower the weight drastically or to work in a much smaller range than we would otherwise need to. So for people that have issues in certain ranges or that are struggling with adding external loads, it's a real winner for them. I think they're the ones that respond to it really well. Or like I said, those that are wanting to do more, but there's a certain limit to what we allow them to do at certain stages. We can use the cuff to allow them to get more muscle activity and to fill that void of them wanting to feel like they're working out, in the near term without actually putting them in unsafe position.
Yeah, we've actually got a podcast on it as well if people want a bit more information, and you can see our cameraman actually using the occlusion device, which is quite entertaining. Okay, so between week 2, week 4, we're really trying to build on that strength. We're also trying to do everything from week 1 and 2, reduce the swelling, etc. Do you want to just talk us through the next stage, and also when would you go on to the next stage?
Yeah, so significantly reduced swelling, fully straight knee, off the crutches, a knee that bends to maybe 80%, if I had to put a number on it. Those people, and quite well-controlled pain, those people are ready for that strength progression. It might be week 4, it might be week 6. Everyone's a bit different, but that's when we start to reduce how much they're simply just tensing their quad. We're starting to reduce how much they're sitting at home just straightening the knee, and we start to move into body weight strength work. We start to move into some modified gym work. So if someone's going really well, it'll probably be week 4 to 6 where we can start to set them up with a gradually progressed gym program or
exactly.
Program.
Yeah, perfect. And most people can sort of picture the general machines that you have in a gym. What sort of exercises would you be doing with the patients?
So there's quite a few different hamstring exercises we might be able to do. It depends what graft they've had.
Yes.
Are they experiencing hamstring pain? Do we need to be a bit slow and careful if they've had a hamstring graft?
Yeah.
But for those people, they are essentially rehabbing a hamstring tear at the same time. So it's important to get them doing some things that they can do. But that might be different bridging type exercises. It might be some light hamstring curls to begin with. It might be just doing some hinging kind of patterning with a dowel before moving into adding some weight to it. Squatting within certain ranges, depending on the person. We can probably get them on a leg press, preferably a pin-loaded one, because that can be quite light to begin with, and then maybe they can build into the 45 weight loaded one from there. Again, from week 4, we can do modified range leg extension if someone is looking good enough to do it.
Yeah.
But we definitely don't do full range from there. Calf strength work, whether it just be standing calf raises, double leg, single leg, before we add any external weight to that. And then we often want maybe some like basic balance work. We definitely don't want unstable surfaces. We don't want eyes closed. We don't want anything that is going to put someone in a dangerous position, but just simply starting by standing on one leg and actually feeling that leg, work by itself for maybe the first time is a good idea.
And it's a confidence builder, isn't it?
Yeah.
Because essentially you've got, if you go back at 9 months, you've got 9 months to be able to do all the cutting movements, the jumping movements, standing on one leg and somebody, if you're playing football, barging into you. So you've got to get through all of those phases over that 9 months.
Yeah.
One of the questions that people will often ask is, when can I run? Do you want to just talk us through either your criteria for somebody running or when that roughly would be?
Yeah, I think historically 3 months has always been the figure thrown about, and I think that's still true. I wouldn't,
and that's treadmill, straight line, predictable running.
So I wouldn't often be pushing any recreational athletes into any jumping based work or any straight line running pre 3 months. I think that's still a good marker to have there, even if people might feel ready for it earlier. I think the surgeons are still comfortable with 3 month being the quickest anyone gets back to it. But there are plenty of people who may not be ready for it at 3 months. So the criteria that we use at that point to decide whether someone is ready or not, there are some functional tests. Yeah. So again, the Melbourne protocol references this quite a lot, and it's really nicely laid out. For single leg balance, the normative data for someone 18 to 35, which is probably the most common demographic for an ACL reconstruction, although it definitely does happen older than that as well, is balance 43 seconds eyes closed and 43 seconds eyes open, 9 seconds eyes closed.
Okay.
We want someone...
Knee fully straight, obviously.
Yep.
Yeah.
We want someone to be able to perform a good-looking single-leg squat down to a bench or a chair. Yeah. And we want at least 10 to 15 repetitions of that to be performed to show that there's some endurance there. We do a feet-elevated single-leg bridge. Yeah. And we want 20 of those. Yeah. We want 20 single-leg calf raises.
And this is what you mean by criteria-based, isn't it?
Yeah.
Rather than saying everybody can run at 3 months, which obviously everybody's different. There's a time element, but there's also a criteria.
Yeah, definitely. And this is all quite clearly laid out for people. So if they can see that they're very much on track for some of these goals, but they're really behind on others, then it tells them where they need to direct their energy as they're approaching that 3 month point, if they're thinking they want to be doing the dynamic stuff as soon as possible. Yeah. There's also I think a side plank endurance test in there as well. There is benchmarks for single leg press 1RM and squat 1RM. Yeah. I think people often surprise themselves with the leg press in terms of how heavy they can actually push relatively early. And it's 1.5 times body weight at 3 months, or at that kind of move to...
and that's single leg, isn't it?
Yeah, it's single leg. We don't often make people do an actual single leg 1RM in the gym unsupervised, but you can easily get a 1RM calculator on your phone.
Yeah. And do 10 and work it
do
back.
10 or 6 or 8 or whatever, and then it'll tell you roughly what your 1RM would be.
Yeah.
I tend to find, unless people were very active in the gym and were very strength-based and were already squatting heavy and deadlifting heavy, I don't think the squat benchmark applies to some of the recreational athletes we see, because if you weren't squatting 1.5 times body weight before the surgery, you definitely won't be doing it after because it's a skill in itself.
Yeah, absolutely.
So
and a lot of people aren't used to being in the gym. That's the other thing, isn't it? Is a lot of people that, a majority of people that will go through the process of an ACL recon have been in the gym at points.
They're active people, but they're not necessarily powerlifters or strength athletes. It's a different kettle of fish altogether. And an 80 or a 90 kilo male will then see that they're expected to squat 120 to 130 kilos for 1RM. that you see their face when they see that on the list. And I often tell them that unless you were big into it before, we can probably leave that one. I definitely want them doing some weighted squatting, but I'm not often too strict on that one.
But we talk to them very openly about these goals, don't we?
Yeah.
This is the criteria that you've got to get to. And there might be people watching it like, well, I'm sure you only do that with all your elite athletes. But this is what we do for everybody, isn't it?
This guide wasn't developed for elite athletes. This was to try and bridge that gap between the kind of criteria and care that people in professional sport were getting and try and adjust it and make it appropriate for just normal people who have active goals.
And also, if you are somebody that's having this done, you're like, well, I've never been in the gym before. We know how to adapt this to people, don't we? We know how to. Not everybody's going to be able to go to the gym all the time. We can adapt that to doing home exercises, etc.
Yeah, I think it's a conversation that does come up. People that aren't particularly gym-based, who used to, like, their exercise used to purely be, I play tennis 4 days a week, or I'm big into paddle, or I play football. But those people don't always like the gym.
No.
And haven't always actually been in the gym. They might not have much gym experience. And I'll tend to tell people that the gym's almost non-negotiable at some point in your ACL recovery.
Yeah.
I think you will really suffer if you have no gym access.
Yeah, I do.
I think it's very hard to get as strong as you need to be without the gym. But I completely appreciate that some people don't enjoy it and they're not going to want to do it longer term.
No.
So if we can agree that for a period of a few months,
2 sessions in the gym, do 1 or 2 at home.
If you can at least give me that up to 6 months post your operation and you've clearly progressed with your strength there, although I'd like people to continue in the gym because there's a lot of research around the need for certain strength markers and how that's protective for future injury.
Yeah.
We have that conversation with people, but I also have to admit that not everyone's going to continue with it. But if you can at least give me that period up until, if everything's going to plan, 6 months, and show me that you've built some proper strength, then we can perhaps adapt that to things that are a bit less gym-based from there.
And actually, it goes back to people that are going to have an ACL. First of all, is this information new to them? Did they know this is what actually it was going to be like? Because what you don't want to do is get month 3 and go, I didn't realize I'd have to go to the gym 3 times
a week. This is it. They need to live near a gym.
Yeah.
They need to know what they're doing in a gym. They need to be able to fit it into their schedule.
Yeah.
Again, these days, I think the education pre-surgery is much better.
Yeah, agreed.
But absolutely, I've had patients in the past who weren't that happy when they met me initially,
and your demands are placed upon them
for them, and they go, well, I had no idea I needed to be in the gym. I don't enjoy it. I don't have one near me.
But it's also should be part of the decision-making process.
Definitely.
I mean, I've definitely had people that are 48, 50, and they're like, I do want to get back to skiing, but actually I was only skiing for a couple of hours every day, and I was going for a nice long lunch. And they're like, I'm not too bothered, actually. And I don't have the time to go through the next 9 months of rehab. But that's a sensible decision, isn't it? Because the worst thing you can do is go through it half-heartedly, end up with a stiff knee that you end up limping on for the rest of your life because you've not been able to commit to what you're doing.
Exactly. There are definitely occasions where surgeons will
put you off.
Will put you off, and will tell certain people if they meet certain criteria, if they're not unstable day to day, and if their demands don't require it, absolutely these days surgeons will tell some patients that I don't think you're a good candidate.
Because let's be honest, most people with an ACL rupture, as long as it's isolated, operate day to day, no problems whatsoever. It's just the twisting and the turning with football or skiing or rugby or any sort of contact sports where the risk goes up. And if you still want to do those sports, then you're going to strongly consider an ACL reconstruction. If you're not, continue on with life. Don't put yourself through 9 months of, I'm not going to say hell, but it's a massive commitment.
I wouldn't get it done if it was me.
No, okay.
Only because I don't play any pivoting sports. And I don't think I ever will again.
No.
My life's very one direction. A bit of running in a straight line, cycling, work in the gym. I don't ski. So I think
that's a really interesting point because I've definitely had patients that have gone to surgeons and said, you've torn your ACL, I'll reconstruct it in 2 weeks. And not necessarily had the conversation, well, you don't actually need to have it reconstructed. I've also got a client that was absolutely had no time for an ACL reconstruction, kids, work. And she said, I just want to leave it and see how I get on. And I know she skis like literally 4 times a year.
Yeah.
And she's got no ACL, but she's absolutely fine. And that's where you take your time, make the decision, find out. But we do know if you're walking around every day and your knee's giving way, you're going to need an ACL reconstruction.
Some people don't have the choice.
No.
If you're functionally unstable, it's dangerous.
Yeah.
And you run the risk of
severe arthritis,
secondary injuries, increased arthritis risk, all those kind of things. So if my knee was giving out going up the stairs, I would have to get it done. And there's nothing against surgeons. I would go and see a surgeon. I would chat to them. I would get my knee imaged after having it tested. I would go through the whole process. But if they looked at me and said, well, you're not horrifically unstable, functionally, I think you'll be okay, it's up to you. I would probably then opt against it. Because like you say...
I don't know what I would do.
Yeah.
Because I do ski,
and
I definitely want to be able to ski like with my kid. So I think
bracing technology's got much better.
Well, we're going to do we'll do a podcast on that, but the idea of it sort of naturally healing, we're going to do something on that because I think that's interesting. And there clearly is research to back it up. You speak to surgeons, obviously they're quite biased and they're not convinced that evidence is going to be that strong, or they find it hard to believe. But anyway, we'll wait and see. So far, we've got back on the treadmill. We're doing some straight line running at around month 3. We've built loads of muscle up before that month 3. What happens between month 3 and 6? What does that look like?
So before we've put them on the treadmill, the only thing I didn't raise was we need to know that they can jump and hop.
Okay, that's an important one to talk about. So
they've got the strength. We then want to see how they go for the first time dynamically. People are petrified the first time we allow them
as in just doing a hop on one leg or hopping off a small box.
Very daunting the first time we allow them to do it. They look at you and they think you're crazy. It's very important to be there with them for that session because most people don't think they can do it
true.
And are really scared that something's going to happen, but then they do a few and they realize they're actually quite able at that point.
But a decent physio is going to go through that process anyway, aren't they?
Exactly.
So they're going to go through your double leg plyos, jumping onto a short
band assisted stuff to make it a bit easier first and decrease some of that apprehension and build some of that dynamic capacity, and then we can get rid of the bands. We can do some double leg, some single leg.
You can even do like leg press. You can get that sort of plyometric pushing off.
We want vertical and horizontal, so up and forward hopping on one leg. It doesn't have to look perfect, but it has to look good enough. You have to see that someone has the capacity to get back up off the ground, that they're coordinated, that they've got some spring.
And also just ask them, how confident do you feel doing it? They go, I don't feel that right. You're not ready to run. And just build that up. And how do you feel? I could feel like I'd do that 1,000 times.
Yeah, definitely. I think that there's no value in forcing someone who doesn't mentally feel ready.
No.
There's a lot of research late stage that athletes that don't feel ready injure themselves more often. I tend to extrapolate.
And that's a psychological marker, isn't it? That's not we've talked a lot about mechanics, physics, physical properties, 1 rep maxes, but actually one of the best predictors is saying to the patient, how confident do you feel on a scale of 0 to 10? Yeah.
And there's nothing wrong with a patient not feeling ready and taking more time to get there. As long as they're in agreement that the next phase will happen a bit slower and the phase after that might happen a bit slower. I've no issue with taking more time with them.
No.
As long as they're not looking at me and saying, well, I must be back at 9 months, but I also haven't done X, Y, and Z. I just have to then be realistic and say, well, you're not on schedule for that anymore. But as long as they're happy to be open with their schedule, I don't mind waiting.
And that conversation, let's say somebody's booked a skiing holiday in February or the football season starts in whatever, September. You're not having that conversation 2 weeks before. We know months before whether somebody's on track, don't we, for that?
You will know within the first 2 or 3 months if someone's already behind schedule. And that's completely fine. It might be they haven't had the time, they haven't been able to get to the gym, they might have had more pain, they might have been a bit swollen. But if someone's a mile behind schedule at months 2 and 3, they're not going to be back at sport at 9 months.
No.
Exactly. And as long as they're aware of that and they're happy with that, then we just slide the back end of the rehab a little bit further out.
No, it's good. So we've done some hopping. We are running now. Where do we go after that?
So we often build like an interval style running program, and how much running someone needs to do is partly up to what we're trying to get them back to. We probably see a lot of patients who injured themselves playing sport that don't want to be runners. They just want to be able to get back to their sport.
So change of direction, the agility side of things.
Do we need a tennis player to run 10Ks? before we let them go back to tennis. No, tennis is short and sharp. And so we need to come to some sort of agreement with patients as to what level of running do we need to build you up to within that 3 to 6 month window if they're on schedule, versus what can stay interval based. But it is very straight line. No change of direction pre 6 months. Within that 6 months, again, if someone's happy in the gym, then they'll be largely unrestricted with strength-based things in the gym. They're not going to be back to HIIT classes and things like that, but they might be doing full spin classes, full work on the rower, running on the treadmill, cross-trainer. There's not many restrictions from like a general gym perspective at that point. So our goal is by that point to get them fully strong, normal day-to-day. By that point, they don't really feel like they're in rehab anymore. They just can't play sport yet.
So there'll be change of direction stuff, but there's not going to be land on that foot, pivot off at that point. No.
And we will very gradually towards the end of that period phase in some lateral movements. We might get people working, even basic things like a lateral step up and a crab walk and a lateral lunge. These are very controlled things. So once people have nailed the forward and back stuff, we start to expose them to some of that side-to-side movement, but in a very controlled way first, making sure that they know that the knee's not allowed to be buckling in and they need to control those forces. And depending on the gym equipment someone has, we might get them doing some lateral work with a sled, just walking. So they've definitely been exposed to some side-to-side things, but not in the context of pivoting and change direction in sport.
And you talked about controlled, controlled versus uncontrolled, predictable versus unpredictable, and I think that's quite important. Obviously, you want to go from a very controlled, predictable exercise environment, and then adding in that more uncontrolled, unpredictable stuff. Do you want to give us a little bit of guidance on that?
So going to the unpredictable stuff.
So what sort of things, give us an example of what that might look like.
We would make it still predictable, but a lot more dynamic first. So we can actually, the tests we use at that phase are not only what someone's horizontal hop abilities are.
So how far can they hop?
So a single leg hop forward, a triple hop forward. We also get them doing a triple zigzag hop. So there's a bit of lateral movement in there. We need to see them within about 5% of their unaffected leg there.
So say, for example, they can do 3 hops going to 10 meters. You'd want them getting to around 11 meters. 9 meters or 9 as a minimum.
5 to 10 there. And there's also lateral hopping tests as well. We, again, in the Melbourne guide, they have a 40 centimeter bit of tape. Jump from one side to the other, time it for 30 seconds.
How many can you do?
Do? Is it close to the other side? So that's quite important there.
And what's that? That's basically looking, we haven't talked too much about neuromuscular stuff, but that's basically, it's not just about the numbers. It's also about looking at how you do it. They often go together though, don't they?
And looking more into the quality side of things, although it's still a bit data driven, through this phase, we use the force plates quite a lot.
So talk us through that, because that's certainly something we're using a lot of in clinic. And how does that help us with our ACL patients?
So it allows us to see, it's not just how high do you jump, but the markers that we can look at will really tell us about the phases or the quality within that jump. On a double leg, on a single leg, we get people stepping off a step and then jumping back up on 2 legs and 1 leg. So it tells us about how much force someone can absorb as they hit the ground, how much they can produce as they propel up. Are they as quick on one side as they are on the other one? We look at a force trace curve. Are they symmetrical, or does someone really struggle in one part of the curve?
Because we're often going to be comparing to hopefully they've got a good leg.
Yeah, exactly.
To see what the differences are.
When they do land, do they bias one side? Are they subconsciously getting off that leg when they're landing, or when they're in the middle of that depth jump? Does someone allow themselves to drop as far down when they're doing a jump? Because often we'll see with ACL patients that they might remain a bit stiff through the knee, not because the knee's stiff, but because
they haven't got the confidence
or the strength. And so they might have a really hip dominant jumping pattern where they avoid loading the knee as much as they can. And we can see that come up with the force trace curve and their counter movement depth. So how far their hips actually drop as they jump. And so we get a lot of information using the force plates as to what's the quality of someone's movement.
Yeah.
Do they lack the reactivity and the speed? And if we're seeing massive deficits there, then that supplements whether they can simply jump as far as the other side.
Yeah.
Are they doing it in the way that they do it on the other side?
Yeah.
Or are they still habitually offloading the knee?
Yeah.
Because when it comes to sport, you don't have a choice.
No.
Knee's going to be tested.
You need it. Otherwise, you're a higher risk of re-injury.
Exactly. And if you have not realized that you're actually still avoiding it, then when it's crunch time on the field, that's when people re-injure.
Yeah. That's really good. And with the force plate testing, and obviously we're basically putting a barrage of tests together, aren't we? And sometimes right at the end of the process, you're putting a barrage of tests for the sort of return to play test. So when are you absolutely ready to go?
Yeah.
But we all know it's not just a moment in time. It's a process. But actually, you're using the systems to know when to move on to the next stage, and also which bit of the rehab you need to focus on. Is it strength? Is it reactive strength? Is it their ability to hop?
Yes.
So it's really breaking down the movements. Yeah, an awful lot of information.
Well, that's it. Because sometimes we will see that people are already running, they're already jumping. We then do some of this force plate testing. We see a few small differences, even though they look like they might be able to hop and jump similarly to the eye. And then we might kind of go back and do some dynamometry testing and realize that, well, actually, there is still a 10 or 15% deficiency in one spot or another.
And we're generally wanting 10% or less, aren't we?
Yeah, 5
in
to
this
10%.
Sort of limb symmetry index, they call it.
Exactly. And if there's one area, it might still be the quad, that everything else is going great, but the quad might still be 12 or 13% reduced, then for that person, the big focus might still be that they need isolated quad strength, even though they're quite late in their rehab. That might be the one thing that's holding them back.
Or if they haven't got the strength, they can't produce the force to jump at a certain range.
Yeah, in terms of power development and rate of force development and that kind of speed component.
Which is essential.
Yeah, the biggest thing that will affect that one way or another is whether you're strong.
Yeah.
If you've got poor strength, your power and your springiness is not going to be good.
Yeah.
So the low hanging fruit is get someone as strong as you can.
Yeah.
And often their power increases. And with that limb symmetry index that you just spoke about, there's quite clear research around the quad that if you're below 90%, your risk of re-injury dramatically shoots up. I think you're 3 times more likely to sustain another knee injury within a 2-year period after returning to play if you're below 90% with your quad.
And that's pretty clear, isn't it, in the research? Okay, so we've changed direction. Obviously, a lot of people were going back to skiing, sport. It's unpredictable, isn't it? You don't know if somebody's just going to barge you. You've got to land on that knee.
Yeah.
Obviously, you can never replicate every movement that potentially can happen. So you've got a nice, strong leg. You've got your agility side of it. You've got your hop tests. Obviously, the last phase is really that sport-specific phase, which sometimes is hard to do in a clinic, isn't it? A lot of that needs to be done outside.
Yeah.
Talk us through that, because that every stage is important. But my experience of recreational athletes is they don't spend long enough on that last stage before they go back to sport. They're like, well, I'm pretty good now. I'm strong. I'm ready to play 5-a-side football. Well,
yeah, I think it's the hardest stage for recreational athletes, definitely, and in our clinical environment.
Yeah.
I think, obviously, in professional sport, the gym and the physio and the S&C bleed straight out onto the pitch. And it's seamless.
Yeah.
That's, I think, where we have the biggest gap because we don't have the space in the clinic to set up a full battery of pitch-based
maybe one day
tests. Yeah, exactly.
We'd have to move out of central London.
But I mean, there are definitely we need to start to make it more agility based. We need to start to stretch things out a bit. We need people to go from just running to actually achieving speed with their running. So they might be on a return to actual sprinting kind of program in a straight line. They need to be shuffling side to side. They need to perhaps be doing ladder drills.
And if it's going to be football, they need a football
involved
as soon as possible as well.
And then we need to leave that completely controlled environment and we need to start to expose people to decision making and to reactivity and to obstacles.
Exactly.
And that works best when someone is a club-based athlete and they have access to pitches and footballs and other players, and then it's a phased return to training from there. But that becomes part of the challenge when someone's maybe trying to get back to casual tennis, skiing, paddle tennis, in that there's not often training sessions for these people. Well, they might have tennis coaching, which might work well, but often it's a matter of I either don't play or I do play.
And there's
so
no in between, is there?
Yeah, and it's tricky to make sure you can convince them that they need to find ways to do it in a controlled environment, and then once they've shown that in a controlled environment they can handle the cutting and the side to side and the different agility drills we give them, we then need them to gradually reintroduce the decisions that come, so that day one back on the court, they're not rushing to a drop shot and have not done that for 9 months and they're stopping on a dime and then turning back. That's where the risk is. So their intensity needs to be lower. Their playing time needs to be lower. They need to be playing against people who know they're coming back from injury. Aren't just going to run them around the court day
don't
one.
Get too competitive.
It needs to be casual first if we have that imperfect environment where they don't have structured training to go back through. Because if they do, you can allow them to participate in the warm-up and some of the early drills in a training session, and then you can pull them out of any of the match simulation stuff, and then you can gradually build the time of their session, and you can gradually allow more match play, and you can have coaches set up drills where they are experiencing contact in a controlled environment, and you can have coaches set up drills where they're then having to make decisions based on directions of players and the ball, but it's still largely choreographed by the coach. And then we can introduce match play for them.
It's a terrible term, muscle memory, but it is part of that, isn't it? They've played football for 15 years. They've been out for probably a year, if not longer, if that, they've done the injury, say 6 months before the reconstruction. They've got to get back, and the body needs to remember how to move in that sport, and it needs to feel natural again before they're even close to going back, really.
Definitely. And even in the professional ranks, often it takes players a while once they're back to sport to feel like they're actually back. You don't go back game one and just feel like you felt immediately pre-injury. It takes time to mentally and physically get yourself back to what you were.
And it will depend on the sport, obviously, in terms of how often we would advise you to go back, et cetera, et cetera. And also you've got to keep monitoring that knee, because if it starts swelling up, then part of our skill is knowing when to hold people back, but also knowing when to push people on.
And that's return to running as well as return to agility or pitch-based things, is even if they're not in pain, if the knee does swell up a little bit, something's happening. It's a sign that we need to pull back a little bit. And I find sometimes it's not just what people do. They might be doing exactly what I've asked them to do, but they might not be doing it exactly when I asked them to do it. I might have said you can run 2 or 3 days a week, or you can do 2 or 3 pitch-based sessions or court-based sessions. If you do that Friday, Saturday, Sunday, because that's when you've got the time,
your knee's not going to like
you get an email on Monday saying that my knee's a bit sore, I only did what you said I could, but people haven't allowed the recovery in between, which is
Really
as important as what we're actually asking them to do. So making sure you have that day off in between dynamic things. It might be a court-based session and then a gym session the day after, or a bike session.
That's part of the skill, isn't it, is programming, what we're doing as well. So we've pretty much come to the end there. So we're at 9 months. Obviously, hopefully everybody gets back to sport. If we just sort of summarise, what are your sort of key takeaway messages for people? Give us 3 for people that are going to be going through this process.
I think as we said right at the start, the biggest thing is you need to be able to commit the time to this. It's we give you a lot of guidance and hopefully we're effective in that regard, but the surgeon's done their job. It really comes down to, if you want to get back to sport, it really comes down to how well you're able to put in the time and build the things you need to build. There's so much work required from the patient with this that the surgeon or we can't do for them.
Yeah.
So knowing what's coming and having the time to do it is...
And that might involve seeing the physio before the operation, speaking on the phone to a physio. We're always happy to do that, aren't we? Speak to people. Or it might be speaking to a patient that's been through it to get some real life experience of it.
Because the research will show one of the biggest factors that will dictate whether you do or don't get back to sport and whether you have further problems is whether you can do all this work. And if you can't, then you won't feel like you've actually achieved your goals after this ACL reconstruction, which leads to the second obvious one is strength. We've spoken about it so much. One of the biggest factors as to whether you will or won't do well is whether you can achieve those strength benchmarks.
And because that strength links into all these other things about ability to be able to hop, run.
And it does require the gym. We need that external load, that the forces we apply to ourselves when we go back to sport are massive. We probably don't even get to those forces in the gym most of the time, to be fair, but it's the only way we can get you moving in that direction to be safe with the forces that your knee needs to deal with and your whole body needs to deal with as you're back to sport. And then I think the third one is, as we've said at length, it's not just about time. It's criteria. There's a minimum acceptable time frame, but so much of the research centers around what we need to achieve criteria wise, and I think it really simplifies things for people in knowing whether they're good enough, whether they have more work to do, whether they're ready, whether they're not.
I think that's great advice. Trust the process. You know, we've done this many times and a vast majority get back to sport, and be patient. It takes time for the rehab process. It takes time for that tendon to become a ligament. Patience is a virtue. Well, Stuart, that was brilliant. So much information. If I did my ACL, I think I'd go for surgery, and I would definitely let you lead my rehab. You know your stuff. So if you've enjoyed that, well, first of all, actually, if you're going to have an ACL reconstruction, best of luck. If you've got any questions, then please feel free to drop us an email. And we've got lots of other podcasts around ACLs, things like which graft is best. And also we've got a really good podcast from one of our physios and his surgeon talking about that process from a surgeon's point of view and from the physio's point of view. So good luck and many thanks for joining us.